Well, good morning, everybody. Great to see you getting up so early in the morning. We weren't sure. This is the first time we've done this slot, isn't it, Brian? So we weren't sure whether any of you would be getting up this time. Welcome to this session on Pathways to Personalized Remission in CLL. I think on behalf of all the faculty, I'll tell you, we're delighted to be here doing this for the CLL Society. We feel very noble that on Corporate Friday that we're doing something for the Society. It makes us feel much better about ourselves as well. So we've got a great faculty for you today. I'm John Gribben, for those of you who don't know me. I'm now in London. Bumped into one of my old patients from Boston earlier on this morning. Very nice to be back here. Actually, that's not true. Orlando's not my favorite city for ASH, but what can we say? At least it's a good convention center. I'll introduce all the faculty to you as we're going along, and I'll try to get Nicole's name right this year. And I'm particularly pleased to have us join with us today Brian Kaufman, whom, of course, for those of you who saw the video, will know that he and his wife originally set up the CLL Society, having now, as a physician himself, been diagnosed with CLL. We'd like to thank Peerview and CLL providing this session, AstraZeneca, B1 and Lilly providing educational grants for the symposium. I can reassure you they had no input into its content. If you haven't already done so, please complete the pre-event survey. A reminder to look out for additional polling during the presentations. Please do submit your questions. We're not going to take questions after each talk. We're going to take questions at the very end after all the presentations are over. Our experience has been if we take questions as we go along, answers are getting handled in the next session. So let's just wait till we come to the end, but keep the questions coming and we'll get through as many as we can at the session at the end. For those of you who are in the room, use your personal device to scan that QR code. I'm sure it will come up again in a moment to respond to the polls and ask the faculty questions if you haven't already done so. Who won the poll? Do we know? No? Nobody admitting it? No? Okay. And for those of you joining online, welcome, where you are. So good morning, good afternoon, good evening, wherever in the world you may be. We're very glad to have you there. Same thing, respond to the polls on your screen and enter questions in the chat window that you have available to you. Here's that scan that you can do that I already told you before. And remember, just to give you a little incentive, we're giving away a gift card at the end. So the more often you go in and do it, the better your chances are of winning, to just give you the incentive to do so. And there's the little sign that tells you that you won. You saw the introduction, and Brian's going to go over this with you in more detail, but just a reminder, you don't have to be taking furious notes the whole way through this. The slides and all the practice aids can be accessed in the activity menu now, and they'll all be downloadable after the session, so all of the slides will be made available to you, so you can pay attention and write your questions rather than trying to write furiously. If you need any more information, the email address is there, and you can join in the conversation on X for those of you still using it. So our goals for today are to learn how practice guidelines for CLL have now been integrated into first-line time-limited therapy and earlier use of the newer targeted agents. The growing evidence supporting finite therapy with modern BTK, BCL2 inhibitor regimens, including MRD-guided treatment approaches. New data confirming the role of non-covalent BTKI inhibitors in relapsed refractory CLL and point to a role. We know that the studies are already ongoing, looking at this as frontline treatment. Optimizing a personalized treatment plan for treatment-naive and relapsed refractory CLL patients. We all know that depends on safe delivery of care and a strong understanding of patients' needs and perspectives. And of course, can't talk about this morning without thinking how important it is to bring in the patient's wishes into the planning for their treatment approaches. They've got as much of a voice in what they want to do as we do. So I already introduced myself. I'm John Gribben from the University of London, and I'm joined here by Brian. So what we're going to do, start for a little bit of time here, is just kind of have a little chat, and then Brian's going to tell you more about what's available in the CLL Society. So Brian, I know you're going to come back in your subsequent slides, because I've seen them already, about the mission of the CLL Society, but you know, what was kind of your goal in setting up this organization, thinking about what you thought its mission would be right at the beginning?
Well, let me start by thanking everyone for getting up early and being here and allowing the patient voice to be a big part of this, and that's what I'm going to emphasize in my part of this. My goal in setting up the CLL Society, when I was diagnosed 20 years ago, and that was before there was any targeted therapies, the prognosis was horrible, and at that time there just weren't any resources that were available. And I was able to leverage my advantage as a physician and an educator to get access. I came to ASH meetings. I found out about phase 1 trials of new drugs that just had numbers and didn't have names yet. And as a result of that, I'm alive today, 20 years later, in a complete remission. I thought, it's not fair that you have to be a physician and be connected and have a Rolodex of docs that you know. Everybody should have access to that. So my wife and I set up to found an organization that would give everybody that access. Our motto is, smart patients get smart care. We want to make those patients smart so that they can work with their physicians, make your jobs easier as healthcare providers, so it really is a shared decision-making. Try to bring those patients up to pace a little bit on the revolution that's happened in CLL healthcare.
Has been a real revolution, hasn't it? I mean, I basically tell my patients nowadays, and they all understand this, that I can just keep them going long enough for the next advance, they'll be able to get on to the next line therapy. And we certainly know that we've got many, many patients alive now that wouldn't be alive without all the advances we've seen recently. So what's the value to patients of a support? Certainly I always have, even before the society existed, always looked to try to get my patients in touch with another patient who'd been through what they had. You're a physician, but of course it's very different being a physician and a patient than being a physician. But it's very baffling for a person with a new cancer diagnosis, and leukemia is a very emotive word. So how do you find that that peer support works?
Yeah, so there's the role of what a patient can do is so different than the role of what a physician can do. So when a patient meets someone like me, and there's many people like myself in the CLL Society, and they see that I look pretty healthy for somebody who's been going for 20 years with CLL, with every bad prognostic marker. It's not like I have an indolent form of the disease, 17p, TP53 mutated, IGVH unmutated, ZAP70 positive, SFB31. I mean, you name it, Notch 1, every bad marker I've got, and here I am. That's an incredibly powerful statement that Dr. Gribbens couldn't give to his patients, you know, but when they see me, or some people who are 35 years out, you know, it's an incredibly powerful statement to do that. But also then the patients can say, yeah, I remember when I got that drug. I remember that infusion reaction. I remember how scary it was. But I got through it, and here I am, and it was just this. Or I got through the headaches that I had for the first few months of this therapy, or the muscle aches and pains or whatnot. You know, it's just an incredibly different kind of support that a patient can give. And the other thing is the cognitive dissonance of the active surveillance period, you know, the watch and wait. We're trying to get away from using the term watch and wait and use active observation or active surveillance so it sounds more proactive.
My patients always call it watch and worry.
Yeah, yeah. So we're, you know, having another patient explain that is just really incredibly helpful. So we have all these support groups to do that, peer-to-peer counseling for that.
Great. What would you say to a patient with symptomatic CLL who's now, as you'll find out, we often are too, bewildered by the modern treatment choices that we have available?
Yeah, I'd say what a blessing. I mean, when I was diagnosed, there was no therapies that were known to extend life. There was no therapies. It wasn't until FCR came along, and it wouldn't have worked for me with 17p deletion, that was shown to actually extend life. So now we have an embarrassment of wonderful therapies, and it's kind of like, you know, if you're choosing, you know, you could say, well, I want a Cadillac, I want a Lincoln. They're both good cars. You know, some people might prefer this one versus that one, a Mercedes or a BMW, you know, or a Ferrari or a Lamborghini. I mean, you can choose. These are great options that you have out there. So I say, you know, look at, you know, it's a shared decision making. What makes the most sense for you? How old are you? What comorbidities do you have? You know, you'll be going through all of this. You know, what's your preference? Is it you want to take something every day that's easy to take? You want to take something that you can get off of after a year or 2 years, depending on where you're at? You know, it's a decision. So it's wonderful to have these choices because there are no wrong choices. There are really great options out there.
I guess the other thing is, of course, unlike, say, acute leukemia where you have to make your decision immediately, you've always got time to be able to really introduce these various choices to people and give them the time to understand what the options are.
And it's an iterative process, isn't it? I mean, when we start talking with CLL patients, most people have no idea what a lymphocyte is. They have no idea what their spleen does. They're not sure. They know they have lymph nodes and they get big when they get a sore throat. They have no idea what they are. So we take the time to educate them. We have all of that stuff. So they become aware, and then gradually these terms and the names for these drugs are so tongue-twisting, you know, for people to remember. So we have to go over it and over it again, but like you say, they've got time. It's very rare. It's just a small minority of patients that need urgent therapy when they're diagnosed, especially in the first world. So it's different in third world countries where often people are symptomatic at the time of diagnosis. Most patients are asymptomatic when they're diagnosed, and they have time to learn this kind of stuff. So, you know, use that active surveillance time to become educated about your disease. Also, it's a time to start thinking about survivorship, which is the big issue going forward in CLL, you know.
Sure. So, you've already introduced the concept of continuous versus time-limited therapy. How are you finding patients view the idea of that nowadays you may be able to get off therapy, and is it something they're attracted to in general? And I guess the other issue there, of course, is, as we'll be discussing among us all this morning, it's not for everybody. So sometimes maybe people might be disappointed finding out that they would want some therapy, but someone's going to give them the advice that maybe that's not the right choice for you with in your circumstances.
Yeah, so the choice of therapy is going to be very individual for the patients. And the reason that a lot of people like the time-limited therapy is they just like time off of therapy. They don't want to be reminded of taking a drug every day. There's an expense, at least in the US, there can be very significant expenses to these therapies. So getting off the therapy can be wonderful. But for some patients, they like the idea of the continuous therapy. The beginning of the therapy is often a lot easier. There's not a lot of lab tests and visits, sometimes even hospitalizations. We're looking at options outside of the US. There's all oral options. These are coming to the US right now, not FDA approved, but certainly on the NCCN guidelines that'll make it a little bit easier. So patients like the idea of being able to take therapy and stop, but other patients like the reassurance. I know that when I started on PCI 32765, which later became ibrutinib, I had a hard time stopping, even though I didn't need to be on it anymore, because that drug saved my life. And I was worried about going off of it. Are you sure I'm going to be okay? Is it all right? You know, your disease is low enough level, you can stop it. You know, I remember Dr. Bird saying, you can stop this, but I didn't want to go off of it. You know, so there is that group of patients who like the reassurance of taking a medication every day, especially if they're not having any adverse events. And it's very different if you're an 80-year-old, you know, than if you're a 50-year-old when you're diagnosed.
Yeah, sure. And how can the CLL Society help patients find out more about emerging agents and how to access clinical trials, a subject we're going to come back to again this morning in the session?
Well, you know, there's all different styles of learning. So we try to, at the CLL Society, we try to make your job easier by addressing that. So I was talking to Dr. Megan Thompson today. She just did a Facebook Live event, which is called Ask Me Anything. So patients can ask about new therapies and whatnot. Then we have specific webinars that we do. We can have 1,000 people attend one of these webinars that'll go over what the new therapies are, what are the new frontline therapies, what are the therapies longer, what are survivorship, so we can teach about that. We have a whole section on our website on clinical trials and how do clinical trials work for patients. What's a phase 1, phase 2, phase 3 trial? What's involved in that? You know, explaining, demystifying that kind of things. And of course, at the support groups, a lot of our patients are in clinical trials, so they can talk to each other. So we have a lot of different ways. If you go to our website, there's always new, I mean, I'm here at ASH. This is just the beginning. I'm going to be writing up, you know, we'll have 40, 50 abstracts that we'll cover from ASH that'll talk about all the new therapies, and we write those in patient-friendly ways. We interview the PIs for that, so we try to make it accessible to patients.
Sure, great. So, Brian, over to you to talk about the CLL Society.
So, for those who saw the early video and just in our conversation, we covered a lot. But essentially, the mission was that we were there to meet the unmet needs of the CLL community. And so we didn't try to reproduce what other people are already doing well. There's other wonderful organizations out there, Healthcare United, Lymphoma Research Foundation, there's the cancer societies. I mean, they do great work. So we tried to fill the gaps in, and those gaps were mostly in education support. And later we got involved in research and advocacy. And we envision a world in which the entire CLLS community can equitably access quality education, support, and care to lead to healthier and richer lives. And there's 4 pillars, and we started with support. We started in my living room with 3 of us. I mean, that's where we started, in my living room with the meeting, and now we have 40 plus, almost 50 support groups across the country that meet, you know, on a monthly basis, now meet virtually because of the COVID. Our website's been visited 6 million times at this point. Our webinars, these kinds of things. Advocacy. We started with small A advocacy, how to advocate for yourself with your physician in terms of what's important to you, to get that across, how to advocate with your insurance company to make sure your drugs get covered. That's a big issue in the US. But now we're doing much more large A advocacy, making sure that these drugs are covered, making sure that the research is funded. We have a lot of issues going on in the US that I'm going to skirt around, but we're involved in all of these things. Also, we're an immunocompromised community. You saw me walk up onto the stage on with an N95 mask on. The therapy I'm on right now is very immunosuppressive, so I wear an N95 mask. So teaching about that, and we're funding research, and I'm going to get to that in a minute. These are some of the resources, and I'm not going to go through all of these, but you can take a look. These were covered in the video at the beginning. But these are all available to your patients and to yourself. We have a whole online toolkit, and it goes through everything, like as I talked about before, for people, you know, how to read their CBC, you know, what vaccines to get, what's a lymphocyte, but also what all the drugs are. We talk about the active surveillance time. You know, you can see that there. We talk about the different drugs. All of these are one-page resources that are downloadable for patients and printable. We have a medicine cabinet that goes through everything, and the medicine cabinet is all patient-friendly, and again, it's to make your job easier. What we're trying to do here is talk about what are the adverse events, what can happen, what to expect, so it makes it easier. We spend a lot of time on how to manage if there's a little GI upset. you know, how to manage if you get the headaches, these kinds of things, what's going on, what to expect. We have and for those here that are investigators, please check out our grant section on the website. We offer Young Investigator Awards, we offer Clinical Scholarship Awards. Those details are all there. The schedule for when to apply and all of that is there. We're very proud to be funding millions of dollars of research for CLL these days. And I think that's it.
I think that's it, Brian. Yeah, absolutely.
Thank you.
Absolutely. Great. So this is exactly what we've been talking about. I think one thing you'll hardly hear us talking about today is chemotherapy. I haven't given any conventional chemotherapy to patients for CLL for a number of years now, outside of clinical trials where there's still a chemotherapy arm of the clinical trial, and even then I don't like those trials because I don't like giving that type of therapy. But you all know we're going to be talking about the covalent BTK inhibitors. The first in class was ibrutinib, which Brian talked about already. Now we've got acalabrutinib and zanubrutinib. We've now got extension of approval for time-limited A+V ±O in treatment-naive CLL. We've got pirtobrutinib, which is now approved for relapsed refractory CLL after prior BTK therapy. And of course, we've got venetoclax approved. So these are the main toolkit that we have, and how to use them alone or in combination, in continuous therapy or in time-limited therapy is what we're going to go on and talk about. This also just shows us for de-identified Medicare fee-for-service records of patients initiating first-line therapy in 2020 to 2024. Unlike what you're going to hear the four of us are using, the use of these agents still much lower in the overall community than we would like to see. And of course, many of the patients not having FISH testing or TP53 analysis testing being done to help select the right therapy. And certainly, I think you're going to hear us saying we certainly use these tests to help select the therapy, and that's one of the things we're going to be talking about today. So with that, I'm going to bring the faculty up on board. I'm going to bring up your identifiers so you can know where to sit, and introduce Nicole Lamanna, who's from Columbia in New York, who's going to take us through upfronted, oh, sorry,
no
put the
worries.
desk in the right way, take us through upfront targeted standards, new evidence and innovative type limited options. Nicole.
Thank you. Well, it's always nice to kick off ASH, and I agree with John about Orlando, but happy to be here in the warmer weather. You can see he got a little suntan, so somebody enjoyed the day. But great to be here and with my esteemed colleagues. So hopefully this is a great kickoff, and please enjoy the meeting. So we're going to talk about time-limited options first, and we'll start with a case. So here you have Amanda, who's 69, so she's a little on the younger side. She has a good performance status, but does have a history of coronary artery disease, status post-stent placement, and well-controlled hypertension. She does have some bulky lymphadenopathy and splenomegaly, and she's unmutated. So just to kick off, do you think this patient is a good candidate for time-limited therapy? And I'll ask my colleagues some of these. Megan, what do you think?
Yeah, so when we look at this patient, 69 years old, and has some comorbidities that are cardiac comorbidities, hypertension, coronary artery disease, I would say in 2025, we should consider time-limited therapy for every patient, given all the options we have available. Some of the factors here might sway you in terms of the status of the cardiac comorbidities, in terms of BTK inhibitors, as well as bulky disease, being higher risk for tumor lysis syndrome. But we're going to talk about many of the time-limited options, and I definitely think they should be considered in this patient.
And then what would you choose with the time-limited options, Ven, Obi, or BTK Ven? I'm going to punt that to Bill. You like that?
Yeah. So those are both great treatment options. We have a lot more long-term data with Ven-Obin, with the CLL14. We know for this patient, the expectation is a median PFS of about 5 years. And that doesn't necessarily mean she needs retreatment after 5 years, so it'll probably be longer than that. We don't have the same perspective yet with BTK plus VEN, and we are seeing very favorable outcomes with a longer duration of treatment than a year. MRD-directed therapy, and we did a trial with 2 years of ibrutinib venetoclax. And so my preference is for this patient, because she has an unmutated immunoglobulin gene, because of what we've seen with our own trials, a BTK plus venetoclax combination.
And then moving on, if you choose
Can I make one other caveat?
Yeah,
if she
absolutely.
had a mutated immunoglobulin
Yep.
gene, I
Then
would
you
be
do-
more interested in OBIN.
Yeah,
Yeah.
fair enough. And if you do choose BTK, BCL2, which one would you do? And should I bring in the question of doublet versus triplet in this case, Meg?
Yeah, so this is a great question. I think we have a good range of perspectives on the panel, and we might differ on this.
Yes.
I have been using the acalabrutinib venetoclax amplify regimen, given the safety data we have with the second generation covalent BTK inhibitors compared to ibrutinib. So I haven't really used ibrutinib venetoclax, although John probably has a lot of experience, and I know Bill has a lot of experience with the study, he said. In IGHV unmutated, though, that amplify regimen, to Bill's point, is a shorter duration, and we do see the IGHV unmutated patients having, just at the 3-year follow-up, a little bit of a shorter PFS. So I might be in the minority where I might still give this patient venetoclax obinutuzumab if we're following kind of the true amplified duration of therapy, but I'm really curious to see outcomes with longer duration therapy. And then in terms of the triplet, for high-risk patients, the triplet certainly does have an excellent PFS. For example, the AVO triplet in the Amplify regimen, and then we've seen many triplets for the bovin triplet, which is in the context of a clinical trial. The triplet does have added toxicity, and I think that really needs to be taken into consideration. So I haven't been using the triplet outside of a clinical trial too much, except in select circumstances because of the infectious risk, but it is an option for certain patients who are really fit and you think you can manage the toxicities.
Now let's move on. What if she is a deletion 17p or p53? So and she still wants a time-limited option. She does not want continuous therapy. So given her patient preference and her high-risk feature, would you consider an MRD-guided approach? John, you want to comment?
Yeah, this is a really good question. And of course, a lot of the clinical trial studies that address this, unfortunately, didn't include the TP53 mutant patients for us to really have a great answer to it. As licensed, of course, the time-limited therapies are time-limited. And of course, Bill, you had a lot of experience of looking at Captivate and being able to go on and use further therapy when needed, and what that therapy should be is still rather contentious. We, of course, are well used to using MRD-guided approaches in other disease settings. It's now, going to be licensed to be doing work in myeloma. We've done it for decades in chronic myeloid leukemia. I think most of us working in academic centres have been using MRD approaches to manage many of our patients in clinical trials, and we know how effective it could be. And certainly in England, where the FLAIR trial was open right throughout the country, everyone's got experience of using this approach. And the idea here is, of course, that you can use it in two ways, but one approach using that FLAIR trial was the speed with which you become MRD negative can then be a predictor for how long you should particularly think about continuing the therapy. The other approach is to just continue the therapy until you're MRD negative, and then a little bit longer, and how long a little bit longer is a bit of a moot point. So I think we're still gathering information on it, particularly in the TP53 setting. But right now, my own kind of view is that this is exactly the type of patient I'd prefer to give continuous therapy to at the present time. But we're talking about what patients wish, and you've said she wants a limited therapy. I certainly wouldn't be wanting to use Ven-Ob here. I think the outcome of the TP53 mutant patients in the CLL14 trial was quite disappointing. So I'd be using a BTK venetoclax inhibitor, probably a triplet, and then using an MRD approach to be thinking about what therapy to continue, and probably moving on to just continuous BTKI until the patient becomes MRD negative.
Okay, so let's go over some of the data we have, although again noted that some of it might be more limited. Here's the NCCN guidelines that most of you are aware of. So obviously for frontline therapy without deletion 17p or p53, you have the time-limited ven, obi, or now due to the amplified data, you have venetoclax and acalabrutinib plus or minus obinutuzumab. You still have chronic continuous therapy with acalabrutinib and zanubrutinib. Note that ibrutinib has now been moved to the other recommended category in the United States, although as duly noted by John, this is still very much used in Europe with ibrutinib venetoclax combinations as well. And then, of course, in patients with deletion 17p or p53, the same regimens are listed, but they also talk about this MRD-guided approach, and we'll talk a little bit about that data. That includes venetoclax, acalabrutinib with obinutuzumab as MRD-guided, or even some data with venetoclax and zanubrutinib MRD-guided, and Bill will show some of that. Here's the amplified data. Again, this was the randomized study with acalabrutinib, venetoclax plus or minus obinutuzumab versus chemoimmunotherapy in the frontline setting. Now remember, this did not include patients with 17p, and this was not MRD guided. And so you could see here that the median PFS favored the acalabrutinib venetoclax arms, which you can see versus chemoimmunotherapy. So again, another move away from chemoimmunotherapy. And you can see that the PFS extended to the IGHV subgroups. And as noted before with Megan, she noted that, we talked about the unmutated group, and you can see here that the AVO arms did better than chemoimmunotherapy for unmutated, but there is a little bit of drop off in AVO. The addition of obinutuzumab, the PFS was a little longer for the unmutated subtype. So when you really split hairs about mutated, which we feel do well with many of these regimens, then we still have a little bit of work to do with the unmutated group, and here the triplet did a little better for the unmutated subtypes. There were higher rates of undetectable MRD with AVO with a triplet versus AV. Chemoimmunotherapy, we also saw high rates of undetectable MRD that we've seen before as well, but higher with the AVO combination. And then safety, there's an updated poster on Saturday at 5:30 p.m., so check that out. You can see here there was no new safety signals with AV or AVO. You can see the infectious complications, though, are considerable. You need to think about that with your patients, of course. They were about 50% in the AV-AVO compared to chemoimmunotherapy. Who would ever thought? We always blamed chemoimmunotherapy on all the infections, but you see we still have them with the modern therapies we're using. And there was more neutropenia, you can see, with the AVO and chemoimmunotherapy arms, likely due to the monoclonal antibody. Very little in the way of tumor lysis, atrial fibrillation, and hypertension across the board. How do we deliver the oral-oral combinations? There's a lead-in with the BTK, so you start with 2 to 3 cycles of the BTK inhibitor at standard dosing, and then you add the venetoclax in the normal ramp-up as per standard of care. And you can see here that really does make it easier when we talk about tumor lysis monitoring, particularly for patients to do this in an outpatient setting, that if you lead in with the BTK, here's the Amplify experience on the right. You can see that the majority of patients, over 80%, had a reduction in their tumor lysis risk. They went from high risk to lower risk after they had the lead-in with the acalabrutinib before doing their venetoclax ramp-up, with only a laboratory TLS observed in 1 patient per arm in the AV-AVO arm. So it makes it much easier to lead in with the BTK inhibitor. Now, what about, we talked just briefly about the toxicity concerns about the triplet, and I think this is something, we're all trying to grapple. Who are the right patients for a triplet, and how to best do that given the toxicity, particularly because many of our patients might be older and have comorbidities. So when we think about that combination, this is a study that is going to be presented as an oral abstract on Sunday, where they added obinutuzumab. The patients were randomized to either receive an early obinutuzumab with cycle 1 or later obinutuzumab starting at cycle 15. And you can see here that when they did it later, that there was a reduction in grade 3 or more neutropenia, 64 versus 12%, and a reduction in infectious complications, 26 versus 5%. And yet at the end of treatment, there's still the level of undetectable MRD. There was no significant difference between the 2 arms. So perhaps this might be a reasonable approach in some of your patients to think about, for those that we might be considering for a triplet, whether or not there's there's better ways we could administer the triplet so they're less infectious and neutropenic complications and not sacrifice efficacy. Now, we're all very much looking forward to seeing the data with CLL-17. This was patients were randomized in a one-to-one fashion for ibrutinib as continuous therapy, venetoclax obinutuzumab for a year of therapy, or ibrutinib and venetoclax for 15 months of therapy. Patients could be unfit or fit, and they allowed for deletion 17p or p53, with the primary endpoint being PFS. And just a little bit of teaser before the oral abstract on Sunday. What's nice about this study, of course, was this is the first a real study that shows no chemoimmunotherapy arm. So I think we're all happy about that, or at least on this panel. With modern either continuous therapy versus fixed duration therapy treatment options. And so again, I think this was a very nice study. And you can see here that the early findings indicate that fixed duration, whether with obinutuzumab or ibrutinib, ibrutinib venetoclax are non-inferior to continuous treatment with ibrutinib. There you go. So you can see the 3-year PFS was very similar across the board, about 80% for all 3 arms. Maybe a slight difference in TP53, although I think we need to see longer follow-up for this at 79 versus the others, ven-obin and ibrutinib-ven in the 60% range. Undetectable MRD was higher, of course, with the ven-obin, ibrutinib-ven combinations versus chronic continuous therapy as expected. But you could see the 3-year overall survival was very similar across all 3 arms. So very encouraging data when looking at time-limited versus continuous treatment. So if you could, on your device, if you're reconsidering Amanda, so again, 69-year-old, she has unmutated IgHV, bulky adenopathy. She does have a history of coronary artery disease, but has a good performance status. Is she a candidate for fixed duration? And if so, how would you proceed? No, she should clearly receive continuous therapy. Yes, treat with ven-obi. Yes, treat with ven-ibrutinib. Yes, treat with acala-ven. Yes, treat with acala-ven-obi, if you could answer. Okay, so we see a smattering of answers across the board. Okay, excellent. I think there's more than one right answer.
Good starting point.
I know. Okay, next slide. Okay, so let's briefly talk about MRD-guided strategies with finite therapy. Okay, so this was the study that John alluded to regarding the FLAIR data. And so this was the randomized study looking at ibrutinib and venetoclax administered in an MRD-guided fashion versus continuous ibrutinib versus chemoimmunotherapy. And as John alluded to, that patients had multiple time points of looking for MRD, and when they detected their first, or I should say, when their first undetectable MRD, they were then, the time for how long they were going to continue ibrutinib-ven would be doubled from that time point on. So if they got 1 year, if at 1 year they were undetectable, then they would continue therapy for 2 years. If they had undetectable disease at 2 years, they would then continue therapy for another 2 years, so 4 years. And so the maximum time point, I believe, was 6 years on therapy. That could be. Otherwise, they came off after that. So patients were, many of the patients were on the therapy more than 3 years. So you do have to keep that in mind when we talk about time limited. But you can see here that because of that MRD-guided approach where patients were on therapy longer, the PFS favored the ibrutinib and venetoclax arm compared to continuous therapy with ibrutinib, and certainly, of course, better than chemoimmunotherapy. So we have to grapple a little bit of that data with, how long is appropriate for continuous therapy, time-limited therapy, of course. But what is another consideration when we talk about our high-risk individuals is whether or not this approach could be used for patients with high-risk disease. And so this is an updated oral abstract on Sunday at 4:30 p.m. And you can see that for the MRD-guided arm with ibrutinib and ven, that patients with deletion 17p, Notch, SF3B1, et cetera, that obviously did really well with this MRD-guided approach. And so this makes it a consideration where we were talking about chronic continuous continuous therapy for our high-risk individuals, that many of us favor that given that data, perhaps there could be somewhere where we can straddle for patients who really want to do a time-limited approach who do have high-risk disease, given data sets like this with longer follow-up. Here is another MRD-guided approach that came out of the Dana-Farber looking at AVO. And it is MRD-guided because patients were, they were allowed to continue therapy if they still had disease, had detectable MRD, and they continued with AV. And so they had patients who were also included with high-risk features such as TP53. 42% of those with TP53 achieved their primary endpoint. And you could see the 4-year PFS and overall survival, 70% and 88% respectively in patients with high-risk disease. So again, maybe another way to bridge for high-risk disease, giving patients possibly extended therapy and looking at MRD levels to guide them so they can have some sort of time-limited approach and yet have better efficacy. And then we're all looking for this data, looking forward to seeing the MAGIC trial, frontline study randomizing patients to AV versus VO. And then they are evaluated at the time point that they normally would complete therapy. If they have MRD, if they're still MRD detectable, they can go on to receive another 12 months of AV. If they're on the VO arm and still have detectable MRD, they would continue venetoclax for another 12 months. Everybody would come off after 24 months. Primary endpoint, of course, is PFS. And so we're looking at this, again, a different way of MRD-guided approach in the frontline setting. Now, if you could answer, we're going back to Amanda, now that she has a 17p deletion, but she still wants to pursue a time-limited option in frontline. What potential strategies would you pursue given the current, albeit limited, evidence, fixed-duration ven-obi, fixed-duration BTK ven doublet, MRD-guided second-generation BTK ven doublet, MRD-guided AVO, and I'm unsure of the role of time-limited therapy in high-risk CLL. If you could please answer. Okay, good. So we're seeing more MRD guided, a little AVO, still some people unsure, chronic continuous therapy. Excellent. Okay. Next slide. Okay. And then just to finish up, what about a second-generation BCL2 inhibitor? So this is data with sonrotoclax and obinutuzumab in an MRD-guided fashion. So patients are treated until progressive disease, toxicity, or undetectable MRD by flow or NGS after 15 cycles of therapy. So patients could come off therapy. They looked at 2 different dosing strategies, 160 milligrams and 320 milligrams. The overall response is very high, and you could see undetectable MRD again very high, 87% with flow, 78% via NGS. There were some PFS events. Obviously, the median follow-up is very short so far for this study. It's only 9 months, so we need longer follow-up on these studies, but this will be an updated oral abstract on Monday, so please attend to that. And then, of course, another randomized study that we're looking forward to with the second generation is zanubrutinib and sonrotoclax versus venetoclax and obinutuzumab, the Celestial study. And so this will be another study we're looking forward with a second generation BCL2 inhibitor compared to standard of care ven-obi. So we'll look forward to data on that. And then Nitin Jain is going to be updating his data on pirtobrutinib, non-covalent BTK inhibitor in the frontline setting in combination with venetoclax and obinutuzumab, or PVO. And so this is going to be an updated oral abstract also on Sunday at 4:45. But you could see here that patients had a very deep, high-level undetectable MRD at the end of cycle 13. With bone marrow, you could see 97% were MRD negative. And so the therapy discontinued. Most patients were able to discontinue after completing cycle 13. There was, again, immature, still short follow-up, but no MRD recurrence at a median about 9 months off therapy. No patients have progressed or died. So please see that oral abstract as well. And so just to recap, Amanda is, treatment naive. She's young. She's unmutated, splenomegaly, and well-controlled comorbidities. I think we will all, talk about her functional status, comorbidities, clinical features, of course, but patient preference we know still is an important feature, whether they want time-limited or continuous therapy. And so I think there are many time-limited strategies that would be applicable to her, whether it's IV, oral, or oral. And certainly, I think, many of us, a triplet could be considered, although, the question is whether or not she would need that considering some of the toxicities and whether or not we can, you saw some different strategies about introducing obinutuzumab a little later that might make that easier in the future. If she had a deletion 17p, we're now starting to see some emerging data on MRD-guided approaches for high-risk individuals. So I think that'll be important. Of course, we need longer follow-up, but certainly there's maybe, something to be said about that versus chronic continuous therapy for some of these patients. And with that, I will pass it on to Bill. Thank you. I tried to.
Great, thank you. And I'd like to thank PeerView for the invitation to present at this meeting and participate in the discussion. I'm going to talk about continuous treatment, which is a little bit different than what I think about most. What I think about most is time-limited therapy and developing new regimens. So this is good for me because it's a nice exercise in reflecting on the data and reflecting on who are the patients that are the most common patients in the community and what are the needs in the community. We tend to see younger patients at the referral centers, but as you know, the median age at diagnosis is 72, and most patients don't need treatment at initial diagnosis. So most of the patients who are getting treatment, particularly in the communities these days, are well into their 70s and into their 80s. So I have a case. It's an older patient who has some comorbidities. Marcus, he's a 78-year-old man, has a performance status of 1. He's married and lives with his wife, who also has some health challenges. And he has symptomatic treatment-naive CLL rice stage 3, so he has an anemia with a hemoglobin of less than 11. Other features of his disease, he has increasing fatigue and palpable nodes, a node measuring 4.5 centimeters, a white count of 160. He has an unmutated immunoglobulin gene and wild-type TP53, no 17p deletion. So older gentleman, some comorbidities, definitely has active disease and a fair amount of disease to treat and an unmutated immunoglobulin gene. So the question is, what are factors for this patient that direct you more towards continuous therapy? So Megan, do you want to comment?
Sure. Yeah, so continuous covalent BTK inhibitor therapy really has excellent outcomes, and as was pointed out, we're going to see the CLL-17 data this weekend, and it looked pretty good for ibrutinib, which we're not using as much anymore, given the safety concerns even. So I think every patient is a candidate for continuous BTK inhibitor. Certainly with the IGHV unmutated subgroup, the outcomes are really, really excellent. You do have to have the caveat, though, of cumulative toxicities, including things like hypertension over time, which certainly we see. The risk of AFib doesn't go away. And then we'll probably talk a little bit about the issue of resistance. And so I think this patient certainly is a candidate, but as we see more and more data, to Bill's point, we do try to do time-limited treatment options. But this patient would do, I think, very well with a second-generation covalent BTK inhibitor.
I should mention that he requested a more simple therapy that would require less intensive monitoring. So Nicole, if you had to rank order those 3 factors, number 1, number 2, number 3, which one how would you rank them in terms of preference for this patient?
Yeah, well, age, not necessarily, but comorbidities and preference, I would probably put equal. I mean, the patient wants a more simple, even though I do think the oral orals would make it much easier to do an oral regimen now, let's say, versus Ven/Obi, but a little bit more practical. But certainly, if they're frail and they're older, I think chronic continuous therapy for an individual like this who wants a simple option, this might be his only therapy. I'm okay with that.
Okay. So we have a couple of standard of care options. Well, we have 3 standard of care options for covalent BTK inhibitors. The OG ibrutinib, then we have acalabrutinib and zanubrutinib, and I'll show you the NCCN guidelines. Those are listed in alphabetical order. But John, Can you comment on which of those three you're considering and what drives that?
Well, I think you've already covered it. Ibrutinib, of course, is the one in which we've got by far the longest follow-up, but of course it's also the one in which we've got the data that tells us there's most toxicity, and it's no longer in the guidelines. So I think we've got the answer that we would use either acalabrutinib or zanubrutinib. I think there's very little to choose between those two, and often it comes down to what's the one in which you've got the most experience in handling. And what I find is some people use a lot of acalabrutinib, some people use a lot of zanubrutinib. And I think it's just down to your choice. I think both of them are really excellent second-generation BTK inhibitors, and I don't think there's much to choose between them. You're going to ask me about the non-covalent first, or are you going to come back to
No,
somebody
because
else?
I'm going to show the data, and I mean, there's really not much there's not much that we've seen so far that would formulate an opinion about that.
No, and of
until
course,
this
there's
meeting.
no direct trial of acalabrutinib versus zanubrutinib. There's a lot of these kind of statistical analysis, put it together, which I take with the caveat that almost all of them have been done by the company that wants to show that their drug is the better one. So I think, and I think we probably will never see a head-to-head trial in that way. But I can't see much to separate those two drugs doing the kind of thing we're not supposed to do of extrapolating from one clinical trial to another. And of course, the issue is, of course, the eligibility criteria for the trials varied, so the population in the two trials are not exactly the same, making it a little harder to do, which is why you need to do that statistical manipulation.
So in the interest of time, I'm going to move on. I'm going to make one other editorial comment. John, you showed a slide with an abstract that I think the Mayo Clinic is reporting on, usage of continuous versus time-limited targeted therapy 2020 to 2024. The news flash for me from that data is that that accounts for about 50% of the patients. And these are Medicare claims data, so patients are getting something else.
Yeah.
I think it's extremely important for us to emphasize that I think we're harming our patients by giving them chemotherapy. I assume that a lot of those patients are getting CD20 antibodies, so hopefully that's what accounts for that other 50%, but it's a little bit disturbing to me that only half the patients have access to what we think is optimal treatment.
I think you're right, Bill, and I think the data does show, unfortunately, there's a lot more chemotherapy still being used in that era, and I think part of our job here is to say, don't.
If this patient had a 17p deletion mutated TP53, Megan, does that change anything of your way you think about this patient?
A little bit. I mean, there's a lot of great data for continuous single-agent therapy. Probably the most data for zanubrutinib from Sequoia Arm C, and the outcomes are really good. So that would sway me, especially in this patient who doesn't want monitoring, to give continuous covalent BTK inhibitor therapy.
Okay. I'm going to fly through the data relatively quickly. Hopefully most of you are familiar with this data because it's focused on continuous therapy, which we've seen over several years now. These are the NCCN guidelines. The part to focus on are the two boxes to the right. On the top is the non-17p, or the wild-type 17p, non-mutated TP53. Both are category 1, and those are both the second-generation BTK inhibitors. They're in alphabetical order, and so you have those two options available if a patient has this abnormal TP53. Looking down below that, again, the acala plus or minus obinutuzumab, zanubrutinib is there. There's also some data, and you'll see it in the updated guidelines, with zanubrutinib plus venetoclax from the Sequoia trial. So just going through the data quickly, the Elevate-TN trial was a frontline trial with acalabrutinib, 3 arms, acala plus obin, acala monotherapy versus chemoimmunotherapy. You can see improved outcomes in terms of progression-free survival for the acalabrutinib treated patients, either monotherapy or combined with the CD20 antibody. The Sequoia trial evaluated zanubrutinib in the frontline setting. The original large cohort that was non-17p deleted patients, cohort A, was zanubrutinib versus chemoimmunotherapy. That was a positive trial, also demonstrating improved outcomes with zanubrutinib frontline versus chemoimmunotherapy. And I believe on this trial, the chemoimmunotherapy was bendamustine rituximab. You can see the 6-year outcomes, certainly an improvement in progression-free survival with a significant hazard ratio. Okay, I'm going to show you a little bit of teaser data for ASH. Pirtobrutinib is a non-covalent BTK inhibitor. It is a super selective oral agent. You can see by the kinome to the far left there. There's very little off-target inhibition that's been reported with pirtobrutinib, and that differs from the second-generation BTK inhibitors as well as ibrutinib. Ibrutinib is probably the dirtiest among the drugs in terms of off-target inhibition. So the one abstract that Jen Woyak is presenting is the Bruin CLL 314 trial. This was a randomized trial of pirto versus ibrutinib. 30% of these patients enrolled were previously untreated. So it was a small cohort. It was a subgroup on this randomized trial. This was a non-inferiority trial between pirto and ibrutinib, and in the red boxes you can see highlighted there the treatment-naive patients in terms of the overall response rate and the 18-month progression-free survival. And you can see there's a trend looking like there's an improved outcome with the pirtobrutinib treated patients. That wasn't part of the statistical design, but I think it is insightful information and data for us. In addition, there's Bruin 314. This is a randomized, 313, but this is the toxicity data. You can see a trend towards reduced toxicity associated with the pirtobrutinib there on the left compared to ibrutinib. The 313 trial was a late breaker trial that is being reported at this meeting. That was a frontline trial, phase 3 of pirtobrutinib versus chemoimmunotherapy for patients with no 17p deletion. You can see the outcomes here showing improved progression-free survival with frontline pirtobrutinib versus chemoimmunotherapy. And this is a relatively short follow-up. It's reporting a 2-year progression-free survival you can see there at the top, but certainly another example of improved outcomes for targeted therapy, continuous targeted therapy over chemoimmunotherapy. I think the other thing from this abstract, at least, I'm feeling more comfortable with the anticipated progression-free survival with pirtobrutinib in the frontline setting. You know, the median PFS on the trials that we've heard about with pirtobrutinib for patients who've had a prior covalent BTK inhibitor is a progression-free survival of 18 months to 2 years, which has been a little bit concerning. I think that's because of the patient population that were treated with pirtobrutinib having been previously exposed to a covalent BTK inhibitor. This makes me a little bit more comfortable with what we can anticipate with pirto, at least with a short exposure where 94% of the patients are progression-free who receive frontline pirtobrutinib at the 2-year time point. Okay, here's your question. This is a 78-year-old patient, symptomatic, treatment-naive, unmutated immunoglobulin gene, limited support from the caregiver. What are your recommendations for treatment, or what's your preferred treatment? Fixed duration BTK inhibitor plus venetoclax, continuous therapy with any covalent BTK inhibitor, continuous with a second-generation BTK inhibitor, or continuous with the non-covalent BTK inhibitor pirto. Great. That would be my choice also. 62% chose a second-generation BTK inhibitor. Okay, let's move on. Okay, 17p deletion. If this patient had a 17p deletion and you were thinking about continuous therapy, this is data that Matt Davids reported with acalabrutinib, and it demonstrates that there's no improvement in progression-free survival when you add a CD20 antibody to the acalabrutinib for this subgroup of patients who have a 17p deletion or mutated TP53. So I don't think about a CD20 antibody in this setting. If you think about a BTK inhibitor, then there are some options, the Sequoia trial had a cohort D a C, and a cohort D. Cohort C was monotherapy with zanubrutinib, continuous treatment for patients with 17p deletion. And Contam has reported on this, and there's an update at this meeting with a 6-year follow-up for zanubrutinib monotherapy for 17p deletion, and we're seeing good outcomes, as you can see, in long-term disease control, although it may be a bit shorter for the patients with 17p mutated TP53 than the non-17p mutated TP53. I think we still need a bit more follow-up to make comments on that. As you know, in RESONATE-2, the median PFS for patients treated with ibrutinib in the frontline setting was 9 years. And as somebody said, many of the patients, I think, will only need one treatment during the remainder of their lifetime. So that was Arm C for Sequoia. Arm D for Sequoia was a combination of Xanu plus venetoclax, and it originally enrolled only patients with 17p deletion, and then subsequently they allowed non-17p deleted patients. And this design allowed for discontinuation of treatment. But I think the criteria for discontinuation were somewhat rigorous, so most of the patients continued on therapy. And you can see with limited numbers of patients, 24 patients with 17p abnormality, 18 patients with wild type or intact 17p, relatively short follow-up, but very good outcomes with this combination at the 36 month time point of 87% and 89% progression free. And then there's an update that's going to be presented on Monday with this regimen. Okay, so the next question relates to this patient. If they have a 17p deletion or mutated TP53, what would be your recommendation? Unsure. I find older patients with high-risk CLL very challenging. Continuous therapy with any covalent BTK inhibitor. Second-generation BTK inhibitor. Second-generation continuous covalent BTK inhibitor, but I consider adding a CD20 antibody. Or second-generation continuous BTK inhibitor. I'd consider MRD-guided BTK plus venetoclax followed by continuous therapy. Okay, second generation continuous covalent BTK inhibitor is first choice, or the MRD guided. I think the other comment I would make is on our trial that we did at Anderson, which was 2 years of ibrutinib plus venetoclax, the progression-free survival curves are overlapping for patients with and without TP53 abnormalities so far. So I think what we'll see with time is reasonably good outcomes with a more extended treatment of a BTK plus BCL2 inhibitor for the higher risk patients. I don't think they do as well with only 1 year of treatment, but I think you can improve their outcomes and give them time-limited therapy as long as you consider extending the treatment. This slide summarizes a lot of the features regarding continuous therapy, and I don't know that there's a lot of information necessarily to go through with you all on this. This is probably things that you already know. I mentioned ibrutinib is the OG of covalent BTK inhibitors. There's more toxicity associated with it. Randomized trials have demonstrated a better tolerability with the second generation BTK inhibitors, acalabrutinib and zanubrutinib. I don't think we'll see a head-to-head comparison of those two agents. I also don't think we'll see head-to-head comparisons of these combination therapies because I think that's not. I don't think many of the pharmaceutical companies are interested in those types of comparisons. So what's going to happen is we're going to be in 3-5 years sitting in front of a list of a lot of different options that are all very effective, and we're going to be saying, oh, and having a lot of debates, I think, about, well, what is your preferred combination, and why did you select that combination, and it's just going to get more and more complicated. And I also think we'll see introduction of pirtobrutinib in the frontline setting and usage in the frontline setting, and the question in my mind, the first question in my mind is whether or not that is recommended when we know that patients can develop resistance to pirtobrutinib and can acquire mutations in developing that resistance that may preclude them from getting a covalent BTK inhibitor. While we know that pirtobrutinib does have activity, it's not real durable activity, but it does have activity in treating patients after a covalent BTK inhibitor. So we worry about sequencing, I think, in that setting, but I think we need more data. At the bottom there are the in-class, I would say, side effect and toxicities. Again, they vary by agent. They all have increased risk for bleeding, and also there is an increased risk for infection. So this is a baseline problem for our patients, as I'm sure you all know. In terms of the case that we talked about, I think we covered all the salient points, and I think in the interest of time, unless there's any comments from anybody, maybe we should move on to our next presenter, who is my friend and colleague, Megan Thompson.
Okay, thanks to all my colleagues for setting the stage. So we're going to talk a little bit about sequencing and the future, really, of targeted options. So we're going to kick it off with another case. So Melissa is 68 years old. She has comorbidities of type 2 diabetes and has a diagnosis of CLL, IGHV unmutated. To date, has not had any deletion 17p or TP53 mutation, and received a first-line time-limited covalent BTK inhibitor, BCL2 inhibitor combination. And finished fixed duration therapy, and we can kind of talk in the discussion. There are, as we saw, many different covalent BTK inhibitor, BCL2 inhibitor combinations, and the duration, as Bill has noted, can be very important. But finished treatment, was in a remission, and then had progression 3 years after the end of treatment. So this is a patient we're now seeing in the clinic. I'll note that this is a higher risk patient given the outcomes we just saw. But Professor Gribben, you have a lot of experience with ibrutinib venetoclax. What do you think about this patient, the duration of remission? Is retreatment an option? How do you think about next steps?
Well, I think you very carefully chose the level of progression to make this a little bit controversial. In my experience, of course, a 3-year duration of response with this therapy is actually quite unusual. I think most people we would expect a lot longer than that. But of course, these are the challenging cases that we want to bring up and discuss. Most of us have thought that certainly if they relapse within 2 years, you'd be looking to change the direction of therapy. You've chosen 3 years to say you could go on now to be thinking about giving some other therapy using these agents again. I don't think this patient would classify by our current standards as being refractory to these agents, so we could go back to it. And actually, I've got some good questions that have come in from the audience of stuff that we're going to come back and discuss at the very end about exactly this type of topic. So I think retreatment is an option. Whether or not I want to go back to the combination again when the duration of response was that short, but I probably personally prefer to be thinking about going on to a continuous therapy or going on to an alternative class of drug.
All right, so we'll get back to more of that in the future discussion, but I want to highlight the Captivate data. So Captivate was a study of ibrutinib in combination with venetoclax, and this really is the retreatment data that is most robust that we have. And so for patients who had progressive disease and required treatment again after a fixed duration ibrutinib venetoclax combination, there's been data reported on 36 patients for retreatment. You can see there 25 of those patients were single agent ibrutinib monotherapy, and then 11 patients treated with the combination. And the overall response rate for both cohorts was around 80%. Short follow-up to date, but this is the data we have with a 1-year progression-free survival of 100%. So proof of concept really here that the combination can be used for retreatment. For the ibrutinib cohort, a 2-year progression-free survival of 91%. So small numbers to date, but shows that both the monotherapy as well as a combination can be used. And looking at time-limited venetoclax, this really has been the standard, the Murano regimen, 2 years of venetoclax with 6 cycles of rituximab based off this Murano study that compared venetoclax rituximab to bendamustine rituximab. And we see the 7-year follow-up data. We do have venetoclax retreatment data for patients, 25 patients here. This is a relapsed population again, but a median progression-free survival of 23 months. And there is, I should note, an ongoing study, the Revenge trial, that is looking at venetoclax retreatment after frontline venetoclax-based therapy. And here we see some retreatment data with acalabrutinib venetoclax. This is the study that we saw earlier presented by my colleagues, the Dana-Farber acalabrutinib venetoclax obinutuzumab MRD guided regimen, which was enriched for TP53 aberrant patients. And we can see there's been 5 patients retreated with acalabrutinib venetoclax. Most of these patients around the 2-year mark. There was 1 patient with very early progression that went on to have Richter's transformation. And again, small data set, but proof of concept that patients who discontinue therapy for reasons other than resistance are not resistant to the combination, and this can be recycled in the future. And then over the summer, we saw some data from the HOVON REVEAL study. So this was a phase 2 study that looked at CLL patients who relapsed after initial treatment with venetoclax obinutuzumab or on a clinical trial initial treatment with venetoclax rituximab, 44 patients. Patients got a 2-cycle acalabrutinib lead-in and then 24 cycles of the combination of acalabrutinib and venetoclax. The primary endpoint of this study was bone marrow undetectable minimal residual disease at a 10 to the negative 4 sensitivity. When we look at the 15 evaluable patients that have been reported on, only 3 patients have met that bone marrow undetectable minimal residual disease primary endpoint, but the overall response rate is quite high. The majority of those responses being partial responses in 64% of patients, but 5 patients with complete responses. And no patient stopped treatment due to toxicity, really highlighting the tolerability of acalabrutinib venetoclax. So lower MRD rates with the acalabrutinib venetoclax retreatment, but this is some of the first data we have in terms of sequencing for a fixed duration upfront therapy and then going to a BTK BCL2 inhibitor therapy in the second-line setting. And this is the bovine study. So Jake Samurai last ASH reported some updated data. So this is a triplet of zanubrutinib, venetoclax, and obinutuzumab in the initial setting. It was an MRD-guided duration of therapy in this initial bovine cohort. And then patients had very, very high MRD rates in the frontline setting with an undetectable MRD rate of 96% in the peripheral blood for the overall cohort. We do have some early retreatment data reported for bovine. I should note that the retreatment criteria was not pure IWCLL retreatment criteria in this study. Patients did have the option of retreatment with an MRD level flow cytometry of 1% or greater in the peripheral blood, or traditional IWCLL treatment criteria. There was a median after this frontline triplet of 29 months prior to retreatment and a median retreatment follow-up of 14 months. Of those patients who were IWCLL evaluable, so who had started for relapse, the response rate to retreatment of a doublet of venetoclax zanubrutinib was 92%. There were 13 patients with MRD data, and 46% of patients had become undetectable in the peripheral blood. So again, small numbers, but proof of concept for a BTK BCL2 inhibitor in the second line. And this is a clinical scenario we're going to see in clinical practice more and more as time goes on after frontline time-limited therapy. So let's break for a question here. So let's reconsider our 68-year-old patient, treatment naive, IGHV unmutated CLL, progressing 3 years after the end of treatment after a BTK BCL2 inhibitor regimen. No additional high-risk features. Would you consider retreatment with venetoclax, a BTK inhibitor, or the combination of the two? And why or why not? So multiple potential right answers here given the evidence we just saw. Okay, and so still some answers coming in here. All right, so definitely I agree. I'd like to see more evidence. And then the majority of participants here selecting, I think the evidence suggests retreatment could be effective in this scenario. So I agree with that. Any comments, Bill? What do you think actually about kind of this sort of case? You have a lot of experience from clinical trials you've participated in with the BTK BCL2 inhibitor combination.
Yep. So if this patient got 1 year of combined BCL2 plus BTK inhibitor and progresses 3 years, that makes me very uncomfortable. On the Captivate study, we allowed for retreatment. The cutoff was 2 years. That was somewhat arbitrary. And the data that you showed in terms of the retreatment those are the higher risk patients because they're the ones that have relapsed, and it's a short follow-up and duration of time for relapse. For a patient like this who relapses and progresses and needs retreatment in 3 years, I'm not as excited about fixed duration treatment for them, knowing what we know right now. I might be more inclined to put this patient on maintenance and say, okay, let's see what's going on in 3 years. Do we have something to consolidate you? Do we have better options? There's a lot that bothers me about this scenario, and so I'm not so inclined to go back to combined targeted therapy to get the patient in a remission and off treatment again, at least today.
Yeah, when you say maintenance, are you thinking like a continuous
Yeah.
covalent inhibitor? Yeah.
And I'd go back to a covalent BTK inhibitor. Yep.
Yeah. Nicole, you agree with
Yeah,
that
I
or
would
do
too.
anything differently?
And I think maybe Bill mentioned this about retesting their genetics and the mutational status. I'm curious, there's something different about this person. So do they have other, covalent BTK mutations or something else that, is why they're progressing sooner? So it would be nice to know, but I would also consider chronic continuous therapy.
Yeah, that's a great point. We really don't know the mechanism of resistance for these patients. We haven't seen the traditional resistance mutations really arise. John, anything else to add here?
No, I'm just going to add exactly that we, of course, I had already said that I would have gone, I kind of agreed with Bill and Nicole. I'm a bit nervous about going back there. I think the data that Matt showed of going back to AV were probably people who had a bit of a longer response than the 3 years that you had here. The question about whether you've got BTK or BCL2 mutations arising in a patient's list is not something we've seen too much of with we see much less in the way of BTK mutations in people with fixed duration therapy. It's one of the advantages of thinking about it. But I guess you would be looking somehow to be thinking, why does this patient have such a short duration of response? Be trying to understand it a bit more. So I'd certainly be looking to study this patient a bit deeper.
Absolutely. All right, so we're gonna switch gears a little bit, and this is a really common scenario that we're all facing in the clinic, and Bill's presentation really set the stage for this. So we have David, he's 72 years old, when diagnosed with CLL, has hypertension, some mild chronic kidney disease, hyperlipidemia, IgHV unmutated, without TP53 aberrancy, was treated with initial acalabrutinib, had an excellent response, has been on drug for 5 years, and now starts to have a rise in ALC, but also progressive symptomatic lymphadenopathy, B symptoms. And so we need to select second-line therapy after progression on a continuous covalent BTK inhibitor. So I think Nicole hit on this. Should testing for deletion 17p be repeated now that progression is clear? And what about testing for BTK and PCL gamma 2 mutations? Nicole, you brought up the point we should be testing patients. Anything else to add about the BTK PLC gamma 2?
Yeah, I mean, again, although there's very limited data, this is where we start thinking about, well, what are we doing next for this patient, who had a very good, this is typical classic for the covalent BTK, somewhere the relapse somewhere between 4 to 6 years. So good remission, but then the concern is, have they developed something else? And then what are we thinking? Are we thinking a Ven-based combination? If they have a newly acquired deletion 17p, do they have a BTK resistant mutation? And then we think about, well, where does that fit in line if we're thinking about a non-covalent BTK inhibitor after? And so I would test for this data. This might help inform my next steps.
Yeah, and that's really Bill, something to add there?
I would just object a little bit.
Oh.
And just to say, 5-year remission with acalabrutinib is short. We have patients that are still on acalabrutinib from the original frontline trial that we opened. So for this patient, 5 years is on the short side. With the ibrutinib, the median reported is 9 years if they're, and we don't see a difference in progression-free survival between mutated and unmutated. Unless there's some issue with adherence, I'm expecting the median PFS to be like 9-10 years or longer with the second generation, although we don't know what that number is yet.
I don't disagree with you, Bill, but I think we're all right.
Yeah.
We're all seeing
I
these
think
patients
this
in
is
clinic, and whatever
very
the
classic,
mechanism is,
yes.
maybe there is an issue with compliance, and we all know from other studies that have been done in other disease settings that our compliance isn't nearly as high as we'd like it to be.
I agree.
But I think we're all seeing patients that fall into exactly this category. You're correct that you'd hope and like to see much longer durations than this, but I think we're seeing this in clinic every week at the moment.
Yeah, this is definitely one of the conversations I'm having a lot in the clinic, and I'd say it's pretty unclear in the absence of randomized data. So we're going to review some of the data here about whether we sequenced pirtobrutinib, which now has a recent traditional FDA approval in this setting, or to a venetoclax-based regimen, which has been the standard for many years now. So to set the stage, what about some real-world data? So Dr. Owen presented this at the EHA meeting over the summer, looking at some retrospective data for covalent BTK inhibitor discontinuation, and this is data from Canada. What did patients get next? In the most common treatment pattern was actually sequencing to another covalent inhibitor or a BCL2 inhibitor. We don't have all of the reasons for discontinuation of the initial therapy, which might play into that covalent inhibitor may be discontinued for intolerance and covalent inhibitor sequence. But the median time to next treatment for the second regimen was 12 months, which is quite short, highlighting an unmet need for further study of novel therapies. So going to the NCCN guidelines, so now we do have a lot of options here, second line. What we select really depends on the initial setting. So we have venetoclax actually in combination with obinutuzumab, extrapolating data from several clinical trials showing that obinutuzumab is a more powerful antibody than rituximab, including the CLL13 study from the frontline setting. Extrapolating that, we list obinutuzumab here as a partner with venetoclax. And then for patients who've had a covalent inhibitor and then progressed, pirtobrutinib is also an option. And then looking at patients, this is really for patients who progress during or shortly after treatment with a prior covalent inhibitor and venetoclax-based regimen. We have two options here that are listed as preferred: lysocell CD19-directed CAR T-cell therapy, and then continuous pirtobrutinib monotherapy as a non-covalent inhibitor. So we saw the data from the frontline studies. This is data update that Dr. Wierda is going to present as a poster tomorrow night. This is the phase 1/2 initial Bruin cohort, really heavily pretreated patient population, median of 4 prior therapies with high-risk features, and a median progression-free survival of about 19 months for the overall cohort. And really nicely, this shows different PFS subgroups. So in the BCL2 inhibitor naive subgroup, a median PFS of 22 months, 16 months for the BCL2 BTK exposed, and for those who had progressed on a covalent BTK inhibitor previously, a median PFS of 16 months, so a little shorter than the overall cohort. And this is the phase 3 Bruin CLL321 trial, which is the randomized study of pirtobrutinib versus investigators' choice of idelalisib rituximab or bendamustine rituximab. We saw this at ASH last year, where pirtobrutinib reduced the risk of progression or death by 46%, with a median PFS in this study of 14 months for the pirtobrutinib cohort, compared to 9 months for the investigators' choice. This is data by Dr. Iyer, who's going to present a pooled data analysis from multiple clinical trials looking at specifically at second-line pirtobrutinib. So I think this is really relevant for the case that we just discussed. Small number of patients, So these are covalent inhibitor exposed, BCL2 inhibitor naive, 37 patients. Most had stopped the prior covalent inhibitor for progression, but there was about a third of the cohort who had stopped for toxicity, which I think is an important distinction because the median PFS overall is about 20 months, but when we stratify the PFS for second-line pirtobrutinib by the reason for stopping the prior BTK inhibitor, when we look at those people who actually progressed, the median PFS is only 14 months, versus those who discontinued for intolerance, the median PFS is much longer, 45 months. So really evaluating the reason for discontinuation is really important to know what to expect from your next line of therapy. And this is data we're collecting as part of a multi-center international study to really look at sequencing with non-covalent BTK inhibitors. So this was last updated at ASH last year. And I want to highlight that for CLL patients who discontinued a non-covalent BTK inhibitor and then had venetoclax as their first therapy, the median PFS for venetoclax in that setting was 23 months. When we looked at patients who received venetoclax, either their first or second therapy after after non-covalent BTK inhibitor, the response rate was around 70%. And so these data are proof of concept that support that maybe you can go from covalent to non-covalent to venetoclax with a PFS of venetoclax of around 23 months. And what about CAR T-cell therapy and who is a candidate? So to conclude this portion, we're just going to highlight that liso-cel is CD19-directed CAR T-cell therapy now approved after a BTK inhibitor and BCL2 inhibitor. 20% complete response rate. You can see from the duration of response curve there that those who responded have very durable responses. And then I think when thinking about this data, it's really important to consider, who logistically is a candidate, who from a fitness perspective is a candidate, and really, what disease characteristics will predict that 20% complete response rate. And I'm really excited to see this updated, this oral presentation on Monday that is looking at real-world outcomes of liso-cel CAR T-cell therapy. So 30 heavily pretreated patients, 6 prior lines of therapy, all with prior BTK BCL2 inhibitor exposure, 90% with prior pirtobrutinib. And the complete response rate highlighted here is around 60% in a real-world setting. And it does look that patients who got pirtobrutinib prior to liso-cel had a very high complete response rate. We'll have to see more data about how pirto was used, whether it was a bridge to the CAR T-cell when we see the presentation. But I think this is important when we think about selecting patients and incorporating liso-cel. So let's go to this question. We have a 77-year-old man, IGHV unmutated CLL, no P53 aberrancy, has hypertension, chronic kidney disease, and progresses after a 5-year remission on frontline acalabrutinib, rising ALC and symptoms warranting switch of therapy. How would you now plan for sequential treatment? All right, so more than one right answer. We're kind of like toggling here. So this is an exciting poll. All right, so about 30% of people are choosing a venetoclax-based therapy, then pirtobrutinib, and about 30% of patients are choosing pirtobrutinib followed by venetoclax. And then we have 22% who's unsure of the best sequential approach to this patient, and that is a very true thing we're feeling in the clinic as well. So looking forward to more data, and I'm going to hand it over to Professor Gribben for the next segment.
Thanks. So I get the task of going on to what happens when you've exhausted all of the great options that they've just been discussing, so new directions with targeted agents and immunotherapy. So let's again start here thinking about a triple refractory CLL patient. She's a 72-year-old woman with relapsed refractory CLL. She's got a performance status of 1, unmutated. She's got deletion 17p. She's got bulky adenopathy. Her treatment history, she had zanubrutinib Bill, this time really short duration with the zanubrutinib, but these are the cases that we've got. Second line, she got venetoclax obinutuzumab. Megan's just taken you through that data. She relapsed 14 months after end of treatment, so again, very much in keeping with a very poor response. Pirtobrutinib progressing after about 10 months, not surprising then, based upon what we've seen in this patient from what Megan showed you in the last talk. So, Bill, would you consider retreatment for this patient?
Retreatment
With
what?
Yeah, quite. Well, would
So,
you ever consider
yeah,
going back to one of the first agents?
This is the type of patient that we would love to see in our clinic because we have a lot of clinical trials available for these patients. So I'll put in an advertisement for that first. The second comment I would make is this patient has been through monotherapy with a BTK inhibitor, venetoclax-based therapy, then the non-covalent. They haven't had a combination. So I would be thinking, and there is combination data with, I would definitely test this patient for mutations, BTK mutations, PLC gamma 2 mutation, and then think strategically about, okay, I need long-term control of the disease. I think based on what this patient's been exposed to and given that they have 17p deletion, combined BCL2 plus BTK may be a great option to debulk and to get control of the disease and get them onto a CAR T-cell-based therapy or a trial that may offer them longer-term control of their disease.
Okay, which is, of course, exactly what we're really discussing here. So she's certainly, Megan, by your criteria, eligible for CAR T, but somebody who's progressed with bulky adenopathy, a lot of disease on board, not exactly what we would consider an ideal candidate. So, so she would be a candidate for CAR T, but I think she now expresses an interest in clinical trials, Bill, which is exactly what you were saying, certainly at the places that you all work. These are what we've got clinical trials open for, because these are the patients that we see as really challenging in the clinic. And of course, we've got to, as Bill had already alluded to here, that even if CAR T is being pursued, there would certainly be a need for some salvage or bridging therapy here, and we have to think then about what that bridging or salvage therapy would be. We'd like to see a marked improvement on the outcome with liso-cel than we saw on the data that we saw, and I think very encouraging data you've already said, Megan, that you ended up with there, showing much better outcomes. I think what we could say is extrapolating from our experience in lymphoma, you're looking to get the patients into a much less bulky disease setting before you take them onto CAR T therapy. So if CAR T is not an option due either to limited center capacity or limited caregiving support, it's time to move on to a different strategy and possibly within a clinical trial. Now, at the beginning sessions, I was talking to Brian about thinking about how do we start broaching with patients clinical trials. Well, personally, I think all of us here will be broaching patients with clinical trials at every line of therapy. And no matter how good our current therapy is, we're always looking to build upon it. How do you engage patients in discussion about the trial options? And unlike the setting where we talked about before, where you're talking about frontline therapy, where you have lots of time, we probably don't have a huge amount of time with this patient to be talking about, so this patient's probably quite rapidly progressing, or at least I would expect it to be rapidly progressing here. So I'd be looking to see, what do we have available? How do we do it? And how do we think about it? And of course, the things I'm going to take you through are thinking about the clinical trial data we've got with things like BTK degraders or bispecific strategies. So one way to be targeting BTK is degraders. I said I was a bit uncomfortable about doing this presentation here because, of course, Megan's done so much work in this area. I'm going to direct all my questions about degraders back to Megan. But of course, there are various different strategies that can be taken. The whole point of degraders is using this polyubiquitination as a process for destroying the BTK. So working by a very different mechanism would tell you, of course, that if you're using something like B16673, you're targeting BTK itself. There's the potential for evolving another mechanism for resistance to BTK. Whereas bexobrutideg, who comes up with these names, utilizes a different way of being able to degrade these. So let's look at some of that data. So we're going to see data of this abstract updated on Saturday, and an oral abstract. This is a phase 1 dose escalation, a randomized phase 1b, looking at 2 dosing, 97 patients with relapsed refractory CLL, median prior therapies of 4, prior therapies are shown here, so very similar to the patient we're discussing here. Many of these patients exhibited BTK, BCL2, gamma-2, and BCL2 mutations and high-risk molecular features. And of course, in the clinical trial setting, you've probably got good access to having many of these mutations being looked at, but certainly at our academic centers, we've got access to these sorts of things. And certainly we would be looking and using this type of technique to be thinking about what we're going to do next. Overall response here, 76%, most of these being PRs. Median time to response quite short, duration of response not reached. Long-term treatment, 30 patients been on therapy more than 12 months, 19 of those ongoing. So again, in terms of thinking about it, this might be the type of agent that would be very useful to be thinking about for either salvage or even bridging towards a more definitive CAR-T approach. The side effect profile, pretty impressive, I think, actually. So we see some purpura, anything that targets BTK gives you this antiplatelet activity, some degree of neutropenia and fatigue, and of course, how much of the fatigue is due to the drug versus the underlying disease is, of course, a moot point here. We do also are going to see at this meeting some updated data showing BGP 16673 can induce deep responses in these types of patients again. 67 patients here. Overall response rate, 86%. Common feature, the CRs are not all that common, even though these patients are responding. Overall response rate at the 200 milligram dose, 15 out of 16. Median time to response, again, short durations of response. So again, thinking that these could be used as salvage or bridging therapies. Median progression-free survival not reached. And if we look at the subgroup analysis, the numbers start to become very small here indeed, but if we look at the responses in the subgroup we're having here, those patients who've had both agents but never had the combinations, more than 92% of these patients responding, slightly lower but smaller numbers if you've had access to being exposed to the doublets. Good data also in the setting of deletion 17p and TP53 mutations. And of course, here we are looking and being able to see available the issue about whether or not these patients can respond who've got BTK mutations, even though, again, you're targeting BTK itself in a different way. The answer is yes. Whether it's PLC gamma-2 mutations, again, small numbers, but yes. And whether or not they've had a non-covalent responder, again, the answer is yes. Cadence 304 is a study that will test this agent in high-risk CLL in earlier lines of therapy. And this trial is going to take relapsed refractory CLL with one or more prior lines of therapy, including a covalent BTK inhibitor, randomizing to a degrader versus pirtobrutinib using continuous dosing. And we'll see what these agents are able to do when we take them into less very heavily pretreated patients than we've seen the data presented so far. So let's test your knowledge a little bit. What are your thoughts on the potential of BTK degraders in triple exposed in other words, patients who've had a covalent BTK inhibitor, venetoclax, and a non-covalent BTK pretreated patients? You either don't know because you're not familiar, even though I've just shown you a little flavor of it here. Unclear if BTK degraders will play a role due to limited efficacy. They're active, but not when high-risk features are present. Or they're active, including when high-risk features are present. Please answer now. Okay, so most of you think they're active. Megan, I said I'd come back to you on this, so I think pretty limited data, but some data to suggest that they are. I guess we haven't really got much in terms of duration of response yet, right?
Yeah, we're getting more and more data. So both the Bexobrutideg data, the Nurix 5948 and the BGB 16673 now, there are patients, ongoing over a year response. Some patients have been on it even longer. And so I'm really excited to see the updated data tomorrow, and hopefully soon we'll be seeing progression-free survival data as well. But I think they definitely have shown clinical activity in this triple exposed patient population.
I guess it's also the case that even though the numbers become quite small, it's not surprising that we're seeing high-risk features, because once you're triple exposed, you're going to be, by definition, going to be high risk. Otherwise, we wouldn't be getting through each of the three lines. Each of those lines of therapy has good durations of response in good risk patients. So if we're already seeing these patients triple exposed, they're going almost by definition to be high risk, aren't they? Right. So the other option, of course, to consider, bispecific antibodies, of course, in lymphoma. These are already licensed and approved. Epcoritamab as an example, although there are other bispecific antibodies, of course, which are available in that setting. But epcoritamab targets CD3 on the T cells, CD20 on the B cells. We know these agents are active in relapsed refractory CLL, including TP53 aberrant and double refractory patients. And there are some ongoing clinical trials looking at epcoritamab, lenalidomide, or R-CHOP, which show some promising activity in Richter's transformation. So certainly the EPCOR CLL-1 trial looks at how we overcome one of the major difficulties we've seen using these bispecifics when they first appeared, was that the CRS rates were higher in CLL than we saw in lymphoma, and people have been looking at different ways in which we can try to optimize that approach to make these easier to handle. And certainly looking at changing the CRS prophylaxis from prednisone to dexamethasone, adequate hydration, different stepping up approaches are able to overcome much of this. And in the optimization cohort, certainly we've seen presented last year data to suggest that this might be an approach more suitable to be treating these sorts of CLL patients. Certainly the risk factors for CRS include having more bulky disease, particularly having a higher degree of lymphocytosis. So does need careful handling. I think we're all getting more used to being able to handle CRS. But these are the patients that, although the companies still always talk about doing this in the outpatient setting, in our clinical trials of bispecifics in CLL, we're usually admitting the patients to be looking at getting them through the dose escalation step-up process. So just to wrap up the workshop here, we've got this woman experiencing progressively shorter remission durations, something we were used to seeing in the era of chemotherapy, but now seeing sometimes occurring in the setting of novel agents. She's been triple exposed, open to CAR T, but more interested in the clinical trials. You should weigh the functional status, the comorbidities, clinical features, and of course, at this session, we've got to say, looking also at the patient preferences. But of course, the patient preference here may be whether or not they're willing to travel to where there is a clinical trial open, which would be suitable for this particular patient's needs. Just a reminder, as Megan had already alluded to in her presentation, CAR T is FDA-approved option, requires planning, at least one prior line of therapy use, attention to logistic considerations, may have to travel, potentially travel long distances to get to a center offering Lysocell. Pursuing a clinical trial is a good option for this triple exposed patient, may even be a good option even if you are considering CAR T, because I'd certainly like for this patient to be debulked before I would take them to CAR T. And trial-based options include BTK degraders, next-generation BTK inhibitors, bispecific antibodies, and I think you'll see also a whole variety of novel agents being presented at the meeting over the next few days. So with that, I'd like to remind you, thank you all. We've got lots of questions already coming in, and the good news is I get to be the moderator, so I get to ask all the questions to everybody else. But do keep your questions coming in, and we'll try to get through as many as we can at the present time. So I'm just going to sit back down and get through our questions here. So I found a good one earlier. Nicole, here's a good one for you. This is from a patient. When you're becoming resistant to a pathway or becoming intolerant, there has been this notion about staying on one pathway before moving to another, and I was staying with a BTK inhibitor versus moving to other. What's your approach nowadays to thinking about that?
Yeah, I think we saw some of this data earlier. I mean, the question is whether or not going from a covalent to a non-covalent and then to a ven-based combination, or going from covalent to ven-based and then non-covalent would be the right strategy. And we're starting to see some emerging data, although limited, to what might be the best approach for that. Of course, we consider in the academic settings we're testing for resistant mutations and things like that. Of course, there's limited data with that, but it's something to keep in mind when we think about if you're going to go from a covalent to a non-covalent, when we think about other mutations like an L528W or so on and so forth. So then whether that, these are very rare and minor mutations, and we don't have enough data to say that, that you couldn't go from a covalent to non-covalent. So we do think about this and we test for that, and it's a discussion that we definitely have with the patients. Of course, I do think it's important to rethink about whether they've acquired a resistant mutation or 17p or complex karyotypes, because then you might consider whether or not you want to do chronic continuous therapy or do a time-limited and BTK-ven combination in relapse. So there is no right answer to this, but I should say, but it's definitely emerging data that we will then see over time whether we certainly have data that you can, and I think Megan showed some of that, you can go from covalent to non and vice versa. I think Bill brought up the point if you have Perto in the front line, whether or not you can then go from non-covalent to covalent, whether or not there'll be resistant mutations that we're concerned about in that sequencing. And so I think we need more data to sort of help us figure out what the best sequence is if you're going to exhaust a pathway or not.
Yeah, and I'll just add to that, just to bring it back to kind of what we were talking about at the beginning. This is where I see the patient preference also coming in, because it is a little bit, there's some retrospective sequencing data, but as we saw, it's pretty limited. And so, to Bill's presentation where the patient wants limited monitoring, the non-covalent BTK inhibitor doesn't have the BCL2 inhibitor ramp up. And so sometimes access to care, support to come in for visits, those other things actually in patient preference is part of the discussion in the absence of a clear pathway.
Here's another patient question. So we saw lots of clinical trials here where one arm remains chemotherapy, and I think we all viewed that that's not what we really want to see. But I think it was Susan, wasn't it, a few years ago that wrote kind of the article on equipoise and the whole ethics of doing this. And of course, we know why companies do this. You want to get the answer as quickly as possible, get the agent approved. But is it ethical anymore to be we're saying it's not even in the guidelines and we're doing a clinical trial with a chemotherapy arm? I won't ask you that to Bill, because you never do phase 3 randomized trials.
We don't do phase 3 randomized trials.
but what's your view on the ethics of it, Bill?
I mean, I think, like I said before, we don't have clear data that demonstrates damage done by chemotherapy, but I think most of us have long-term perspective on patients who've had chemotherapy, risk for MDS and AML, and their immune dysfunction. And I think we have great treatment options for our patients now. We do a disservice to our patients if we're giving them chemotherapy. So I'm not inclined. The problem, as you said, is if we're working on therapeutic development and finding new regimens that are more effective, that timeline, if we're looking at progression-free survival and not having sort of a straw man to compare to like chemotherapy, it makes it harder to develop new treatments. So hopefully we'll have MRD, if we're talking about fixed duration treatment, as sort of an intermediate endpoint to look at, and that's an initiative that we're working on. But yeah, I don't think there's a place for chemotherapy today for treatment of CLL. And actually, I have not given patients for years now chemotherapy, including patients with a mutated immunoglobulin gene not getting FCR.
Yeah. There you heard it, everybody. Even the MD Anderson doesn't use FCR for mutated patients anymore, despite all their fabulous data in that cohort. But Ven-O is better. I guess as the transplanter here, I'd say I've probably transplanted more patients with MDS following CLL treatment than I have CLL patients themselves. So I'm looking for something, of course, we don't see nowadays emerge with these types of therapies. Here's another question. We talked about looking at TP53 mutations, but we didn't talk about where the types of the mutations were, what the VAF would be. Megan, is this something you look at when you're doing these type of analysis in your practice?
Yeah, I mean, this is a really important question that needs to be characterized a little bit better. There's been some really nice work looking, and what we're talking about is basically, when you do the testing for P53 aberrancy, of course, you can have deletion of the P53 gene on the chromosome, so that's deletion 17p, but about 2/3 of patients in the relapse setting also on the other allele have a concurrent mutation or change in the DNA, and that's done typically by next generation sequencing testing. And there's a whole range of P53 mutations, some of which appear to be pathogenic, some actually appear to be less impactful or maybe are non-pathogenic. And the German CLL study group a couple years ago had a really nice pooled analysis presented, I think, at EHA 2024 that some of these mutations are really important, some may not be. And the VAF, or variant allele frequency, looks at and I'm oversimplifying this, but in the clinic looks at, how you can think of it like a cancer cell fraction of how many cells carry this mutation, because there's a lot of heterogeneity within the disease biology. But I do think it's important. I do look at it, but I don't think there's been data clearly established that we don't have great clinical guidelines yet to say, these are the really bad actor P53 mutations, these ones maybe less so. There is some data that having the deletion 17p and a concurrent mutation, that double P53 aberrancy is probably worse. So I pay attention to it no matter if it's there. And then the other thing that comes up in the clinic is germline P53. Can occur relatively rarely, but is something you don't want to miss. So I actually do test patients for inherited P53 mutation as well when I see that present. So I think we'll hopefully have more data to come on that, and a really, really insightful question.
Bill, would you ever anymore use alemtuzumab for a patient that's become refractory?
I have not used alemtuzumab for a number of years. For a long time, there was an extended access that we could get it. I don't know if that program is still available or not.
Yeah, because it became so expensive because it moved to multiple sclerosis, right? Yeah, sure.
I think the last time I used it was for pure red cell aplasia, but that was a long time ago.
Or T-cell disease.
Correct,
We
or
use it
T-cell
for
disease.
PLL.
Okay, somebody's sent us here's an interesting case. Let's turn to you, Nicole. 96-year-old patient with no significant comorbidities, disease progression 4 years after Ven-O, currently presenting with fatigue, weight loss. How would you think about approaching this patient?
So you said 96.
96.
Well, God bless.
Yeah.
And how many years after Ven-O?
4.
Okay. Obviously, there's always the concern. There's always the question of retreatment, of course, that can come up. And now it's 4 years. But I don't think a second generation BTK looks good to me for this 96-year-old. Yeah. Assuming this is a fit person, but even not fit, the second generation I think would be fine. So I probably lean more towards that, unless she wanted a fixed duration and was fit, wanted to get retreatment. That's another option, of course, or BTK, then second generation. I guess that's a potential option as well. Wide open on that one.
Sure.
I
Okay.
think I would do chronic continuous.
Yeah. Well, I just thought it was interesting.
Yes.
Interesting that we're even thinking about treating a 96-year-old,
Yes.
and we've got options that are available to do so. Oh, Bill, here's one for you. Did you ever think about bridging with high-dose methylprednisolone and an anti-CD20 antibody?
We have done that. There's data with the high-dose methylprednisolone CD20 antibody that's generated several years ago. Tom did,
That was the
it was the CLL Research
CLL
Consortium
Research
trial.
Consortium trial.
And high dose, we're talking about methylprednisolone, a gram per meter square, actually, for 3 to 5 days with CD20 antibody. That's a reasonably effective regimen at debulking. It works in patients with 17p deletion, but those responses are not durable. So if I'm thinking about using it, and I have used it, everything needs to be lined up and ready to go for a CAR T. And you get some additional immunosuppression, obviously, with the high-dose methylprednisolone. And don't do it before you pherese a patient.
Yeah, I was going to say, I'd pherese the patient first, get the cells off, and then bridge it. Are there any particular agents that you think about using as salvage rather than bridging? And, I guess a lot of the lysocell type studies have incorporated a BTK inhibitor. Would you ever consider using it as a T-cell immunomodulatory agent, even in the absence of thinking it might have activity in the CLL, for instance?
Like a BTK inhibitor?
BTK
My
inhibitor.
preference, based on the data that we've presented from Transcend CLL 004, my preference is to give a BTK inhibitor
Even when they're refractory?
Even when they're refractory.
Yeah, sure, okay.
Yeah.
So the
But
point,
let me just make a comment. So when you say refractory, that's growth while on a BTK inhibitor. You can slow the growth even in the setting of refractoriness with a BTK inhibitor. So there is activity with the addition of ibrutinib or acalabrutinib, even in a patient who's progressed on it and has a mutation. The disease doesn't grow as quickly while they're on it. And I do think you get immune modulatory activity with the combination.
Now, Megan, we're used to the concept that when somebody progresses, you can watch and wait. But if somebody's progressing on a BTK inhibitor and you're going to go next to Veno, do you take them off therapy, wait till they fulfill criteria, or do you think the data's there that they're going to progress rapidly off it and we want to treat this patient before they're bulky for a risk of TLS? How do you approach that patient?
Yeah, that's a really good question, and I think it's where like a bit of the patient-specific art comes in, because there are patients who are beginning to progress on a either covalent or all the time in my practice now non-covalent BTK inhibitor, and you see a little lymphocytosis. They technically meet progression criteria, but the nodes are small, and those patients, even to Bill's point, in the presence of a BTK-resistant mutation, can sometimes get a couple more months out of treatment. So you really have to pay attention to the disease tempo. Of course, at that point, I'm planning, I'm monitoring carefully, but I do think that sometimes we, may have the urge to stop treatment a little bit earlier than maybe we need to. And this is a chronic disease. You can stretch the therapy a little bit more and be ready to go. So in the case of venetoclax, outside of a clinical trial, I do always overlap, to your point, the BTK inhibitor, whether it's covalent, non-covalent, with the venetoclax ramp up or anti-CD20, depending how you're giving the regimen, because these patients can flare really quickly. I totally agree that the BTK inhibitor is still doing something in terms of controlling the disease, and often those patients who have these BTK mutations are very B-cell receptor signaling dependent, and so keeping that inhibitor on for an overlap period is really important.
Yeah, I agree with Megan. There's many patients who can go on for quite a while, some of these. I think the ones who tend to take off more quickly are the high-risk patient population, the 17p. And of course, we're watching those people a little bit more frequently because they might progress quite rapidly. But some of them can go a year. You see the lymphocytosis, but they're otherwise fine and they have no adenopathy. And so you can milk the drug a little bit longer. And I definitely agree about the overlapping. If they're not going on another a clinical trial, so that they don't flare, it makes it easier for the overlap.
Ibrutinib's not in the NCCN guidelines anymore, but the combination still is, right?
It is in the
it's there.
NCCN guidelines still, but it's not
Not as
preferred category.
What I was
it's
leading on
another
to
option.
was, given that we've got so much more data on I plus V versus A plus V, anybody would consider thinking that as being a reason to do it? And if a patient came saying their preference was, well, you've got long-term data on I plus V and the A plus V or Z plus V is short, would you consider using it, or are you more concerned about the potential toxicity profile and you'd rather go with a safer combination? Megan, you're looking.
Yeah.
there.
I mean, I feel like I've probably used I plus V, the least because I have the least experience here in terms of time and drug development on the panel. But I really don't use it in clinical practice, given the other options we have and given the safety data with ibrutinib, but I acknowledge the data is there and looks great. And I think this is just one of the things that, when we talk to European colleagues, they're using it all the time. It's the preferred option. And so really, I've thought about it, but I end up not using it. But I'm curious to know others outside of a clinical trial, whether they would be starting that now.
Well, you're right. I mean, we've talked about this for a number of years here because in Europe we've had access. That's the first thing I can remember, having access to drugs in Europe that you didn't have in the US. But we've had access to I plus V and been using it very widely outside of clinical trial for a number of years. And of course, we're just in the scenario of getting A plus V approved. Now, we haven't had access to it. So we've been the opposite. We've only had I plus V for a number of years and don't yet have A plus V. But we're back to that situation of we were talking about at the beginning of which covalent BTK inhibitor you use. Do you use the one you're most familiar with, or do you use, I think you go with the data, and we have to say that we do see better safety profile data, and we're probably going to be moving all to it. Sorry, I'm just looking to see questions that we haven't already really moved through. So thanks for them all coming in. You talked about this in your presentation about the duration of response once somebody becomes MRD negative. Going the other way, if you've got somebody on V plus O and you're monitoring MRD and they become negative very quickly, would you ever consider giving a shorter duration of response?
Well, there are some studies looking at that. And so, I mean, I think that there's certainly some reason to do that. I think we need longer follow-up, of course. But, when we think about some of the patients, the mutated patients who do so favorably with these types of regimens, that might be an ideal population to stop therapy earlier. And so I do think, we have a trial, Then Stop, Megan and us and others are participating in. And so, looking at MRD guided approaches, that might be reasonable in your favorable population to think about something like that. And I think we just need longer term follow-up and also to see other subgroups like unmutated. Maybe that's not the way to go based on some of the data we've seen with some of the time-limited combinations. Perhaps they should go a little longer or have additional agents added in, as I showed you before with the triplet combination. So maybe the unmutated may not be so good to do that for, but the mutated might be an ideal population to think about shorter durations possibly.
I've got a couple of questions here about allo transplants for CLL, whether we still do it and when we consider referring it. So I think I published a paper a few years ago showing that the number of transplants had almost fallen off a cliff with the new agents available, which made perfect sense. We've seen how effective these therapies are, and many of the patients that used to have to go to an allo can be very well salvaged. But of course, now that we're seeing triple refractory patients again, it's kind of potentially raising its head again, and certainly does become an option, but we're back to the same situation we're talking about with liso-cel, in that we know already that to get a good outcome for an allo transplant, you want the patient to be in as close to remission as possible. So of course, you still want agents to be effective, but you certainly don't want to take them to a therapy as toxic as an allo transplant, particularly in the age group in which most of our CLL patients sit, when you've got other options you could use. So it's about weighing up the risks of the benefits. I guess it's pretty much the centers offering liso-cel or the centers probably offering allo, and I think we'd all be thinking about the potential for where one would fit versus the other. Bill Anderson, where are you offering CAR T, and are you still thinking about allo in some of those patients?
We offer it before CAR T, before allo, and there are patients we do refer to for transplant. It's the high-risk patients with 17p deletion. They tend to be younger, and because of the issues you spoke of, the tolerability and toxicities associated with allo, it still is sort of the last sort of resort. I think things are a little bit different though now in terms of transplant and when a patient potentially goes to transplant compared to historically. The patients are in better shape. because we're not beating them up with chemotherapy. Although my impression is that their disease is more proliferative, and I worry about the mechanics of the transplant and the need for some period of quiet disease while the transplanted cells do what they're supposed to do. So I think this is an important topic, and we'll probably talk more about it. More recently, over the recent years, we sent very few patients for transplant, but I think, as you said, we'll start seeing that increase with time.
Nicole, here's another one for you. We've seen, of course, the bruising risk, but bleeding's actually quite rare with BTK inhibitors. But if you actually do see a patient bleeding, and of course we've quite often got these patients on dual antiplatelet therapy plus a BTK inhibitor, do you ever consider any kind of assessment of bleeding risk? I don't think any of us consider ourselves to be coagulation experts, but do you ever involve your coagulation colleagues to be thinking about investigating those rarer patients who seem to have more bleeding problems?
Yeah, I mean, I guess if there's a consideration that seems more out of the norm than what we're used to for the BTK inhibitors, and I think that also applies to all the BTK inhibitors, whether covalent, non-covalent, and even the BTK degraders. Of course, we see a lot of bruising with them as well. If it seems something excessive, yes, I do.
Okay. Well, for those of you who we didn't get through your questions, I do apologize. I think we got through a vast majority of them, but I'd like to end by thanking you for joining us this morning. Again, after the session concludes, scan the QR code to claim credit, access the activity, and hopefully win a little gift voucher. I'd particularly like to thank Nicole, Megan, and Bill for, as always, really expert advice throughout the morning and for taking part in this presentation.
And we'd like to thank John.
And also to thank Brian and the CLL Society for all the work that you do and everything you do for our patients. So thank you very much and enjoy the rest of the meeting. Thank you.
Okay, everyone.